Good morning everyone. I am Dr. Vijeta and today we are continuing our class on gonadotropin treatment. Let's discuss the step down treatment regime. So in step down treatment regime, the pattern is similar to the spontaneous ovulatory cycle. Let's see the normal ovulatory cycle and the hormones in the normal ovulatory cycle. So let's concentrate on the FSH. FSH will first increase and then it will decrease due to the negative feedback by the increased estrogen. This will lead to the recruitment of the follicles which has high FSH receptor or high affinity with FSH, lead to the formation of dominant follicle and which will ovulate. So similarly, in step down treatment regime, the serum FSH, like the gonadotropin we are giving, is more in the initial days and then it will decrease. In step down treatment regime, as the word describes that it is step down, we will start with an increasing dose and then will we gradually decrease the dose. So the basic physiology we have described in the previous slide, that it will lead to the recruitment of the dominant follicle. So we'll start with the high dose, that is 150 to 225 international unit of gonadotropin, and then we'll gradually decrease it. This will only promote the development of more sensitive dominant follicle, thus will inhibit the less sensitive follicles and recruitment of the single follicle. Step down treatment regime, as we have discussed in the previous slide, it is the physiological treatment regime. That is, we'll start with higher dose of gonadotropin and then slowly we'll go to the lower dose of gonadotropin. But the main disadvantage is that many patients are very sensitive to even low doses of gonadotropin. Thus, in this regime, we'll start with high dose. It will lead to increased chances of OHSS. So, how we can deal with it, that in that way that if the patient has undergone one or more previous cycle, then we'll see the response, the dose at which the response achieved in that cycle, and we will start the step down regime by using that threshold. So it will lead to the decreased chances of the side effects. Thus we'll combine the two, or we can do a combined approach. That is, first we will start increasing the dose of gonadotropin till we achieve a response, and then we will decrease the dose of gonadotropin if we see a dominant follicle. This is the combined approach and it will prevent the side effects. Let's discuss one more regime, that is sequential treatment with clomiphene and then gonadotropin. In this cycle, what we will do, we'll start clomiphene citrate at 50 or 100 milligram daily, and then we'll follow it with gonadotropin treatment on the last day or the next day of the clomiphene treatment cycle. The main advantage is that the cost will be reduced by 50% or more. So basically, for the cost reduction, this regime is used, and the monitoring is same as the standard gonadotropin stimulated cycle. So we'll now discuss the monitoring of the ovulation induction. Why we need to monitor the ovulation induction is because we wanted to achieve our goal, that is achieve the ovulation with minimal side effects. What are the main side effects that we want to monitor? That is OHSS and the risk of multiple pregnancies. So for this we have to monitor the cycle so that we can prevent the OHSS and prevent the multiple pregnancy and achieve our goal of ovulation. So gonadotropin therapy can be monitored by using the serum level of estradiol and the transvaginal ultrasound. And also the endometrial thickness is very important indirect measure of the endometrial development, as well as it help us to prognosticate the implantation. If, for example, if the endometrial is thick, it will show that the adequate estrogen is produced by the developing follicles. Let's discuss about the serum estradiol level. So first we'll discuss whether we have to measure the serum level in the morning or in the evening. So the serum estradiol level should be done early in the morning. The main advantage is that so that the results will be available by the midday, and the new instruction regarding the dose and the treatment of the next schedule will be conveyed to the patient before the evening dose is due. So if the patient is taking the dose at around evening 5 o'clock to or 8 o'clock, if the estradiol level is very high, so we will reduce the dose by around 2 o'clock, will convey this message to the patient, and the patient will receive the lower dose in the evening. So this is the main basic thing regarding this. Let's discuss some important fact about serum estradiol. So serum estradiol level will rise at a constant exponential pace, and during the just before the peak follicular development it will double in approximately 2 to 3 days. And the rate of rise will help us to guide whether to increase or decrease the gonadotropin dose. So, in a natural cycle in which only one follicle will develop, the peak level will be between 200 to 400. Similarly, in the stimulated cycle, for each mature follicle, we will observe a value of 200 to 400. If we have, for example, 8 follicles, then the estradiol level will be like 200 into 8, that is 1600 to 3200. So what is the importance of serum estradiol level? Cycle fecundity will increase with the serum estradiol level, and also the chances of multiple pregnancy and OHSS increases as the serum estradiol increases. So with the existing gonadotropin regime, the best results were obtained when the estradiol concentration will be between 500 to 1500 picogram per ml, and the pregnancy is very rare if the levels are below 200 picogram per ml. After discussing the serum estradiol, let's discuss the ultrasound role of ultrasound. So in ultrasound, what will we see? We'll see the size of the follicle, the number of follicles, and we'll perform the first ultrasound after 4 to 5 days of treatment, and then according to the response every 1 to 3 days. In normal ovulatory cycle, so the recruited antral follicles will appear by day 5 to day 7, and the dominant follicle will emerge by day 8 to 12, and by around, if the follicle reach 20 to 24 then the LH surge will occur. Let's answer the question when we will start the next cycle. So if there is no residual cyst or gross enlargement of the ovary, then we can start the next cycle immediately without any intervening rest cycle, as it has been seen that fecundability and the cumulative pregnancy rate is higher when we start the consecutive treatment cycle without any break. So what if the ultrasound show a residual cyst? So in this case, we'll postpone the cycle because the presence of ovarian cyst will be difficult to distinguish between the emerging follicles and the ovarian cyst. Thus, it will lead to error in interpretation. Thus, we can give these patients a cycle of oral contraception for the regression of the ovarian cyst, and then start the next cycle after a break of one cycle. Let's discuss the results of gonadotropin treatment. So, in case of hypogonadotropic hypogonadism, if we induce the by using gonadotropins, then fecundity rate is around 25%. And if we give cumulative pregnancy rate after 6 cycles is approaches around 90%. But if in case where there is clomiphene resistant and we have given gonadotropin after clomiphene resistance, the range will be around 5 to 15%, and the cumulative conception rate after will range from 30 to 60%. So thus the patient with hypogonadotropic hypogonadism have a good success outcome like 25% with respect to the clomiphene resistant group, which has around 5 to 15%. Let's discuss the complication. So the overall complication of spontaneous miscarriage in gonadotropin induced cycle approximately around 20 to 25%, which is higher than the generally observed, that is 25%. And the multiple fetal gestation correspond to 5 to 8% in clomiphene treatment, and in gonadotropin it is more, that is 15%. The also increased risk of OHSS and gonadotropin are not associated with increased risk of ovarian, breast, endometrial, thyroid, colon or cervical cancer. Cycle cancellation, when we will cancel the cycle. So if the 2 follicles are more than 15 mm or if 3 follicles are more than 10 mm, then we need to cancel the cycle. This is all about the gonadotropin treatment. I hope you enjoyed the lecture. Thank you.